Hello, and welcome to the Neurocritical Care Society podcast. I'm your host, Nick Morris from the University of Maryland School of Medicine and Shock Trauma Hospital. And today, as part of our Perspective series, I'm really excited to welcome Diane McLaughlin. Diane is a board-certified nurse practitioner in acute care. She's practiced in critical care for the last 20 years and is nationally recognized for her clinical expertise, research, and education. She's a fellow of critical care medicine and a fellow of the Neurocritical Care Society. And Diane, thanks so much for joining us on the podcast.
No, thanks for having me. Excited to be here.
Great. Well, you have the distinct honor, I think, of being the first APP that we've interviewed as part of this Perspective series, where we're really trying to get in a little bit into the history of neurocritical care and get views from the diverse group of people who work in this field. And so maybe you can talk about your own journey into neurocritical care and how you got here.
So I kind of landed in neuro a little bit of a backdoor way. I actually started as a critical care nurse up in Cleveland Clinic, working in one of their many cardiac ICUs. And we were overflow for neuro, which doesn't seem like it makes any type of sense, but actually the unit that I worked in now is the neuro ICU. And then I became a travel nurse, and it was during a time that everybody was opening up neuro ICUs, which is a trend that's continued. So like it or not, I started to learn how to take care of these patients. Then when I went to school to get my nurse practitioner degree, I was actually working for organ procurement, which was an interesting blend of neuro and not neuro at the same time, because all of my patients were pretty much brain dead, which means I learned how to manage organ systems very well, but also learned how to do a very good coma exam to help ensure that we were truly working with brain dead donors, which was the case. Then outside of school, my first job was in transplant critical care. And then I became a nocturnist and then covered both transplant critical care and neurocritical care. And then I just fell in love with neuro all over again. So the same reason I wanted cardiac as a nurse is they said it was the most difficult for nursing to learn. And that obviously is what they say about neurology as well. And I believe it because every day that goes by, I realize that there's so much that I don't know, even as I'm learning. And I think that's going to be the case for a very long time.
Yeah, so that raises the point, I guess, of how do we or how should we prepare NPs or PAs to work in neurocritical care? If it is so difficult, then I think it is perceived as perhaps intimidating. How do we get people up to speed so they feel comfortable working in our units?
I mean, a semester of NP school is definitely not enough. I'm a huge proponent for postgraduate training programs, and this is somewhat controversial. So any hate letters, please don't send them to me. But you are prepared as a generalist when you leave school. And so you could probably safely work as a hospitalist, not a neurohospitalist, not in a neurocritical care. So I don't think that the training that we receive postgraduate should be much different than what physicians are receiving. We should have specialty training that's dedicated to both didactic and hands-on, even incorporating some simulation. And there are very few of these programs in the country, but I'm hoping there are going to be more and more and more.
Yeah, me too. There was a really wonderful presentation at the AN this year on the program at Duke within sort of this postgraduate neurology APP program, but it wasn't really directed specifically to neurocritical care. And I don't know that any program has done that, although we have a critical care fellowship here at University of Maryland, from which we actually end up hiring quite a few of our APPs because we find it to be so advantageous to getting them ready to work in our ICU, and they spend time with us during that year, and it's really important. So do you know of other programs that are out there currently?
So I do. The first such program was at Metro Health in Cleveland, Ohio in 2019. And it's a neurocritical care neurosurgery blend that actually paired with Cleveland Clinic and sent their fellows to the epilepsy program at the clinic. It's a good program, and I know their first graduate is still there. so good retention. Since then, I believe there are 6 other programs that have popped up that specify neurocritical care, but a lot of the general critical care ones do dedicate time in the neuro ICU. So a lot's happening, a lot more programs popping up every year. But the neurology was one of the first postgraduate programs, period. So
Mhm.
a great program to throw like a shout out to, I guess.
Yeah, no, absolutely. I think what they were doing there is really revolutionary. And as you said, it has increased their retention, which is good for them, but it's not good for the rest of us, right? Because they're training all these great people, but they're keeping them at Duke, which I guess inspires the rest of us to provide that training, but it doesn't allow us to benefit yet from their program.
Yeah, that's very true.
Yeah.
But that's the goal, right? Homegrown, keep your people. What does it take to keep highly trained people?
Yeah, so let's talk about that a little bit more because I think this is a frustration sometimes in neurocritical care units. It certainly has happened here at University of Maryland at different times where we may get a group of new graduates who are pretty green when they start, and we sort of take a lot of time and care in getting them trained, and they get to be really good, and we're really, really excited. And then they kind of move on, and often to positions that, where there's a little bit more stability in terms of the hours, or perhaps yeah, I think it's often just around the hours. How should, you've been working within this field for now decades. So what's kept you in it, and how do we keep others from kind of jumping ship to take more 9 to 5 type positions?
So I have to be completely honest with you. Even though I've been in the field a long time, I have hopped around a bit, mostly for personal reasons and never for lack of love for the job. But I do think that's part of what's kept me interested in the position. This is another national problem. From a group of 10 APPs, you can expect one to leave each year. So a 10% turnover. And if you're talking hundreds of thousands for the cost of onboarding,
Hmm.
you have to wonder whether it makes sense to take that money and instead invest it in the people that are there. And you could do that either incentivizing additional projects, bonuses, pay increases. APPs are in an interesting spot because a lot of them were nurses. And nursing over the last few years has become very lucrative, which means it's easy to leave a position, go to another one, and get an immediate bump in salary, have more control and flexibility over your hours, take a travel assignment. I think anybody that worked during COVID, uh, nurses did make good money during that time. And so if you came from that background when you're an APP, and please know that I am aware that physicians don't make what I think a lot of people think physicians make.
Right.
But APPs are in the middle of that range. And sometimes you have nurses, as their salaries inflate, are bumping up with what APPs are making, which still is less than what physicians are making. So it's finding a middle ground. And we probably have almost shot ourselves in the foot with this because as nurses make more, APPs make more, and then physicians need to make more. And at some point, you can't sustain this. And we're probably reaching that point sooner than later, which is why you need to start doing the other things. You need to make schedules that make sense. You need to, actually think having additional projects reinvigorates me and gives me energy. So encourage people to get involved in other societies or to have their own quality improvement or research projects, but then give them something for dedicating this time to do so. Either give them time, give them bonuses, give them recognition. Those are the things that really keep people in positions.
Yeah, I really like this idea of sort of rethinking this retention issue from a financial point of view and saying maybe instead of reinvesting that money that would go into a search for a new position, maybe you reinvest in the staff you already have. I hadn't heard that idea. I like that a lot.
Well, the other thing that's interesting is, so I've worked at Mayo Clinic in Florida for going on, what, 11 or 12 years now. And working in critical care for 20 years, there does come a point that, having a patient bleeding to death isn't very exciting. In fact, it's like, oh my gosh, I don't want to deal with this today, which I think is part of the reason I like neuro. Very our sick patient is very different than a trauma sick patient,
Mm-hmm.
right? But there has to be a place for people to sunset their careers that is still able to affect critical care. And I think one of the neat programs that Mayo's done is this acute care at home program. And I've seen, I believe Emory has a telecritical care program. And so there are ways to have people that, don't get the same rush from intubating and throwing 100 lines in somebody, but still love the critical care thinking, having a place for these people.
Right. I'm not familiar with I think you said the Mayo program at home. Can you tell me a little bit more about that?
Yeah, so these are patients that, 10 years ago probably would have been in an ICU. Now, mostly would be on med surg or teleclinics that are able to stay in their own house, be hooked up to remote monitoring, and have a nurse practitioner examine them every day and come up with a plan of care, all from their bed.
Oh,
And
very
so,
cool.
yeah, it's a neat way to help with hospital census, still provide great care for the patient, but in the comfort of their own home.
Oh, that's really interesting. And yeah, maybe we can touch on that later. This idea of, I like how you put it, sunsetting, or sort of transitioning towards the end of your career into different roles. But since you mentioned that you had hopped around at a few different programs over the years, maybe I can ask you, based on your experience, how do you view the best integration of APPs into a neuro ICU? I've seen it done in different ways, and I don't know that there's a complete consensus here.
Well, that's been interesting because despite the job is the same everywhere, is the truth. You have brain injured patients that require care. And having seen it from private hospital standpoint, a teaching hospital standpoint, teams that have residents and APPs only, have multiple teams that are segregated or integrated. The truth is, as long as you have patients that you're autonomously caring for with physician oversight, you're pretty happy. But it's been interesting to see that the role is not the same for every APP, even in the same
Mm-hmm.
practice. So if I might be taking care of patients autonomously, coming up with the plan, really just running it past the attending who may or may not make suggestions. You might have someone else on the team in the same role that is reporting off to the attending who then comes up with a plan and dictates it. And I do think that's necessary, but at a certain point, you should be growing the team to all be reaching that same autonomous point. I mean, I'm actually interested in your opinion on this. I would think the dream as an attending would be to have everybody functioning autonomously while you can still steer the ship overall.
Absolutely. I think that's the goal. Yeah, you're touching on something that really hits home for me, and I think this is challenging for attendings, particularly challenging. I'm 8 years in now as a faculty member, and I'm just sort of maybe finding my mid-career footing. But I think we have, lucky enough to have some very experienced APPs where I am, and some of them have landed in different spots, maybe. So as you're saying, some are truly autonomous, and I feel superfluous, and my job is mostly to say, yep, that sounds good. And others, despite similar experience, might not be at that same level of autonomy. And I don't know that we have a great way as attendings to push our APP colleagues to all reach that same level of autonomy, I guess, or expertise. And because there is a wide variety in the training where people come in, and at any given time, there are people that need more or less support. I think it's kind of always accepted that maybe some people need more support. I don't know. What do you think?
I find it interesting that I feel like if you were training several residents, if one wasn't quite doing the same or growing while you're with them and overseeing them, there would probably be some type of conversation that would occur. And I'm not sure that, and I don't know why this happens, but my belief is that maybe there's not as much feedback because of fear of how it's taken,
Mm-hmm.
because this is someone you're going to be working with potentially for years. And so that's where there's a little bit of a dichotomy that occurs between the training of physicians and APPs. I would hope that regardless of your training, you would receive the same feedback like, hey, I see that you always do this whenever this patient comes in with this. You don't need to do that. Wait and see what the exam does, and then
Yeah.
we'll make a decision to do that. And I don't know what the reason is. If people believe because of the nursing background, we might be a little more bullheaded or a little bit more sensitive to feedback, but it's just as valuable, if not more valuable to us because we aren't going anywhere.
Yeah. Yeah. I guess I wonder maybe if we talked about the issues with retention, maybe that plays somehow a role into this idea of like, well, I don't want to offend them. And then, they're going to be out, working at the hospital across town because maybe that will seem better to them that no one will give them such negative feedback. I'm not sure. I wonder, do you think there's a difference in kind of professional identities among physicians and APPs that contributes to this?
Absolutely. One of the things that I really admire about physicians, you will never hear a physician say something negative about another physician publicly. Like, and that's something that seems to be embedded in the training. And I do think it's something that's lacking in APPs. And quite honestly, probably more so in nurse practitioners and PAs. And I think there's a
Mm.
little bit of nursing culture, which comes from a million women working together. So God bless the nurses out there for helping bring up the testosterone a little bit. But there's a little bit of this mean girl thing that can happen. And I've never heard that happen with physicians.
Yeah. I think maybe it happens a little bit with physicians, but it doesn't
Kind
happen
of
that
better.
much. Yeah. Maybe it's a little quieter. But yeah, I just actually, I'm thinking back last week, we had a really interesting session here on microaggressions between specialties, right? So you will hear that kind
Oh,
of but
yeah.
between specialty talk, but I think we are this more of a cohesive force within the same specialty. Yeah.
Yeah, I think that's true.
Yeah.
It does make
Um,
a big difference as well for retention. You shouldn't have people considering leaving because of Mean Girls. That's ridiculous at this stage in our career.
yeah, I completely agree. What are some other pitfalls in integrating APPs into a unit? If what have you seen that really just doesn't work well?
I think it's difficult, even though it makes some sense to have APPs in charge of physician residents. It happens all the time. We're on the unit all the time. We have the expertise, but there is a little bit of a noctur derogatory undertone sometimes
Hmm.
for this upcoming group of residents. And legally, as of now, APPs can't oversee procedures or the care of physician residents. So I think we have to be careful with that while not knocking our value or expertise. There are some very specific ways that we could be used without being credited for direct oversight. So I think that's one of those pitfalls you have to be aware of,
Yeah. Yeah.
while still promoting, experienced APPs as somebody that can offer value and knowledge without putting them in an overseeing position.
Yeah, no, this is it comes up all the time and we've been thinking a lot about it here. Of course it's we're just in July now and we have the new fellows coming, right? And we do have really wonderful APPs here and some of whom have been with us for, a decade or longer. And not only do they know neurocritical care, but they also know our unit and our culture and they can't help but be someone who transmits a lot of information to the new fellows, but at some point they're not their direct supervisor. And when it works well, and I try to cultivate this, but I guess it's always seems a little bit of a little bit of a crapshoot to not to be able to come up with a better term, but somehow some combination of fellow and APP, it seems to work really well and they're collaborative and there's this sort of seamless transition from being almost a student to then becoming a supervisor of the APPs. And sometimes it doesn't work so well and I have a hard time putting my finger on it. But yeah, what do you think?
I mean, I think that it's true. Like, you never really know how it's going to work until you throw a lot of people together, but it certainly can work. I feel like maybe it sounds like I'm being a little bit negative towards some of this, but it's probably a cold dose of reality. When it works well, it's because everybody not only independently is very capable, but everybody's humble enough to know that whether it's day one July intern or day 27 attending that breezes by, knowledge can come from any source.
Yeah.
And if you're humble enough to be open to that, the team is going to work well. It's the minute people start to get really territorial and very defensive that that system breaks down. And we probably don't put enough emphasis on these soft skills. But the truth is, if the team is not functioning in that manner, patient care does ultimately suffer.
Absolutely. Yeah, that's interesting. I think these soft skills are non-technical skills. I think you're totally right. We don't spend a lot of time sort of explicitly talking about them and teaching them, and yet they are so important. In fact, you could argue that they might be more important to overall care than a lot of the kind of less frequent things that we do. Yeah, I haven't seen any APP programs that sort of incorporate those non-technical skills as much. I think it's a big part of nursing, actually. They really work on it, but then it doesn't seem to transition to the APP programs beyond sort of kind of learning how to present in the way that we present on rounds.
I think we're trying to start incorporating it. I know I've been working with leaders from other postgraduate training programs across the country, and we put in emphasis on making sure that you're learning things like communication, like microaggressions, doing even simulations with how do you handle conflict. And so I think it's coming because we're seeing how important it is. But no, I don't think APP training or physician training probably underscores how important it is, which is why, again, there's so much value in postgraduate training programs.
Yeah, agreed.
Oh, and I love some of these new efforts that I'm seeing to do multidisciplinary simulation. I don't know if you have a lot of these in your program, but I love seeing like Case Western does a mock page that includes nursing students to NP students to PA and physician med students. And I love seeing how everybody integrates their role even before they're doing this in practice. So it starts to open up those communications and take down some of those barriers that exist before you step foot into a unit as a new grad.
Yeah, no, I completely agree. We started almost 2 years ago now with in situ simulations in our unit. We took advantage of the fact that we had to close some beds because of staffing shortages related to COVID and honestly related to the expense of staffing a unit that's changed since COVID. And so where we never really had any open beds in the past, now we do tend to have one open bed or two open beds in our unit. And we use those to do simulations every other week with anyone who might care for a patient in the unit, from everyone from the techs to respiratory therapists, and the APPs feature in them heavily. And it's been great. We decided at first we thought we were going to focus on some of the kind of rare events that we see and kind of the technical aspects, but it became immediately clear that what we really needed to focus on were all these non-technical skills and, how do we communicate as a team, and how do we create situational awareness, and how do we monitor others for safety issues and ourselves. And so, yeah, we've really focused on this, and it's, I think, been a huge hit in our unit. And I think we do better because of it. We're working on some work to show that, but it's still pending.
I was going to say, I hope you disseminate this out there because I do think this is what the future is. And the more people that draw attention to the need for this, the better.
Yeah. Maybe we can kind of turn the page a little bit on this conversation and focus on something else that you've been part of. So you as you mentioned, have been reinvigorated by doing work outside just the clinical work, and you're really known as a master neurosynologist. And I think I've kind of worked within NCS and SCCM doing ultrasound courses, and I'm really fascinated by this because I find as we talk about the role of APPs, one area where a lot of our APPs don't have a lot of education in is ultrasound. So one, how did you get interested in ultrasound? And two, how should we as you say, disseminate this knowledge and get it to the bedside?
So, I mean, the way that I got into ultrasound, honestly, it started as a huge fail, which I think will tell you that as anything, we need to be resilient. But I was probably like a week off of orientation. So I was still eager to do any procedure that came up. And somebody from the other side called and said, "Hey, we need to put a central line in this patient that's having ICP crisis." And I was actually working transplant at the time. And of course, I could not be over there soon enough. And the patient was hypotensive. We laid the patient flat, and, IJ is very clearly there. And the carotid was a good inch away. And so I was like, okay, well, no problem. Like the carotid's nowhere near the IJ. I put the line in, and I had some trouble because, as we know, sometimes when patients are hypovolemic, the IJ will just collapse.
Mhm.
And so one of the methods is you go through and then pull back until you get flow. And so I went through and pulled back, and I had one beautiful pulsatile flow.
Mm.
And I said, I don't know about this. And so we put the wire in, threaded an angiocath over, like just the angiocath, and hooked it up for manometry. And the blood fell. Like it didn't spurt out of us. So we were reassured that this was in fact venous and she was just low volume. And so put the line in, felt pretty good about getting this difficult placement. And the chest x-ray comes, and the line just perfectly abuts the spine. And I look at it and I say, "Oh, I've never seen it look like that before." And so, nor did the person that had called me over to do this. And so we call the attending over, and the attending says, "I don't know where that is. That's not in the atria, though. That's not where it
Mhm.
should be." And so we ended up disconnecting the arterial line for a minute and flushed this catheter. And certainly it was arterial. And so what I had done was the patient's vert had an anatomic abnormality and was quite anterior. I was not looking for anything other than the IJ in the carotid. So it didn't even
Mm.
occur to me to look for this. And so the patient was fine, but had to go to surgery because it was a through and through injury. So there weren't any real complications beyond that, but I was terrified to do anything. My hands would shake, and it really, being brand new, completely knocked me away from being functional in the role. And so our medical director at the time, Jose Diaz Gomez, who is active in Neurocritical Care Society, but also Society of Critical Care Medicine, took me under his wing. And he took me to every course that he did,
Mm.
which included SCCM, included a anesthesia course that he put on with Cleveland Clinic. And he ended up putting us through almost a fellowship where we dissected pig hearts. We went and spent time with a sonographer, and then we had simulated shock scenarios and that we would have to have agreement with the attending. We would have our own measurements, our own images, and make sure that it compared. And that's what built my confidence back up. And to the point that it's very difficult to work in a unit without an ultrasound now
Yeah, yeah.
because I'm so used to using that whenever there's something undifferentiated. But what I love about the story is it tells you, one, again, be humble. You don't know what you don't know sometimes until it's important. Two, we will all have failures. Like, how do you come back from it? And three, you can be a master of anything if you put the time and dedication into. And so with that, because I was doing it so much, I ended up on an ultrasound committee for SCCM, started working faculty with them, made lots of great contacts like Artie Sarwal, who taught me even more about neurospecific ultrasound, and haven't really looked back. I always have something ultrasound related on my plate, and I
Yeah.
love it.
No, I love that story, and I talk about this with my fellows, and sometimes it comes up with the APPs. I think all of us have had some event like that, right, where it's made us weary to go back and kind of get back in the saddle and do it again. And I love that you took maybe what was a perceived weakness and turned it into a strength through training. I guess what strikes me about the story also, though, is that you really went out of your way, and so did Dr. Diaz Gomez, to train you, and that still to this day, it seems like we have to go out of our way a little bit to train in ultrasound, and yet on a day-to-day basis, as you said, I think we can't function without it. So something seems wrong with this. Like it seems like this should just be a core competency that everyone's learning in their training, and
I think
yet it
it's
hasn't
getting
quite
like that.
translated yet.
So I know med schools and PA schools do require at least exposure to ultrasound. Acute care programs don't. They don't require it yet. They recommend it, but don't require. And then again, that's going to be a role for postgraduate training programs to say, no, you need to be proficient in identifying these landmarks, to knowing what the potential complications are. I mean, there are a million stories about how ultrasound is dangerous in the hands of somebody that
Yep.
doesn't really know what they're looking for. I remember waking and attending up in the middle of the night for what I thought was a mass, and it turned out to be the gallbladder. Like, the only way to learn it is to be doing it all the time and have people that are patient and willing to teach you. You can't really learn it on your own. And if you're going to pay $1,000 or $2,000 to go to one of these courses, and the courses are great, they're a great foundation, but then you go home and you don't do anything with it, you've just wasted your money.
Yep.
You have to be scanning every single day.
I think that's so key. What are the most common reasons you find yourself picking up an ultrasound probe these days? Like line placement, obviously, was probably one, but what else are you often using it for?
So undifferentiated shock is the number one reason I'm using it, to try to identify what the volume status is, whether we can go up or whether we can go down, which I would argue to say is half of what we do in neurocritical care,
Yeah.
is resuscitating and de-resuscitating, which is so important in our patients. And I think we'll see more emphasis on the de-resuscitation part in the coming years. That hasn't quite caught yet. I like to use it for also patients that I'm concerned or have increased ICP but don't have an ICP monitor. It's a little bit of a parlor trick, but I do find it useful, and it's more likely to sway me to do osmotherapy in patients I might be on the fence for, because I'm not necessarily a fan of putting everybody on continuous infusions for some random sodium goal.
Mm-hmm.
I think we all have our little like pet peeves, but that's for sure one. But if I have any evidence that the patient might have poor compliance or increasing ICP, then I'm more
Yeah.
likely to do it.
And they're mostly doing optic nerve sheath diameter
Or transcranial Doppler and
or
looking
TC.
at increased velocities.
Yeah. Great. Well, where do you kind of see your work in ultrasound going? You've done so much. What excites you right now in ultrasound?
So it's not like public knowledge yet, but I might be going on a trip with SCCM to Israel and Palestine, which to me is like a little bit of a life dream, to go someplace where people really, really need it and teach them skills that we probably take for granted here. So I'm
Mm-hmm.
super excited about that. Um, and then we're doing both SCCM and NCS ultrasound courses. So one in August in Chicago, and then at our annual meeting in October in San Diego. But in general, I would love to see more nurse practitioners get this knowledge. Uh, Anything that I can do to promote. I know I've looked at trying to have a grant process to have scholarships for at least a few for some of these national courses, or providing regional courses, which is something we did in the Jacksonville area, that we had it intramural funding, but opened it to all of the hospitals and did a day-long course. Because we're the ones at the bedside now. We're the ones there,
Oh,
like
absolutely.
day out, middle of the night. And even if you can't interpret it, if you can obtain the images, you have something concrete to show.
Yeah. Yeah. Well, I know it makes a huge difference to me when, I'm on call at night and it's 3 a.m. and there is undifferentiated shock or, rapidly rising pressure requirements. And I get a call from the APP. And one of the first questions, well, I know who it is. So I know which ones are sort of facile with ultrasound and which aren't. And if they are, I'm just so relieved, right? Because then I know that they're going to give me some really important information that I can use or help them use to make a difference. And if they're not, it's really challenging now for me to think through how to sort this out without ultrasound, because that's where my mind goes.
I would hope so. At University of Maryland, you guys have one of the most well-known shock protocols in the world.
No, we are pretty lucky, and we do have a wonderful APP group. Um, so maybe besides ultrasound, because I think that has been a huge development in neurocritical care, over the last couple of decades in your work, what are some of the big breakthroughs that you've really found exciting?
So this is a little ridiculous as well, but I'm a big proponent that less is sometimes more. And so, like, my doctoral work was in sleep deprivation caused by serial neurochecks. And absolutely, as a nurse, I hated taking care of neuro ICU patients because it just seemed like we were doing all of this worthless stuff. So now I have a lot more education. Will tell you, I'm very aware that it is not worthless. However, in a lot of patients, the juice wasn't worth the squeeze, to say. And so to see us now liberalizing away from
Yeah.
the hourly neurochecks for a week, for 2 weeks, like, it really, in my mind, is torture to do that to a patient, but it's almost worse to do it to the nurse. So I love that we've moved away from that. Um, where I don't know that we've made as much progress as we would like is how do we both diagnose and treat vasospasm and subarachnoid hemorrhage. That's something super interesting to me. And I see, there's like a flavor of the year.
Hmm.
I think we're headed back towards like a milrinone flavor. Um, and do we treat radiographic versus does it have to be clinical? And so that's really one of the things I love about neurocritical care is that we don't have answers for everything yet. Um, Probably the biggest thing I've seen through the course of my career, though, is when I was a nurse, we didn't have TPA yet initially. And so through the course of my career, we've gone from stroke patient, turn Q2, terrible outcome, to TPA, better outcome, to thrombectomy, even better outcome. Sometimes patients that you'd never know had a stroke, now to like everybody gets thrombectomy.
Yeah.
Um, it's crazy that that's happened in my lifetime at the bedside. Just imagine 20 more years what it's going to look like.
No, it's really been incredible. And I've asked that question now to many people on this podcast. And the acute stroke story keeps coming to the forefront as, this is the paradigm that we hoped we can achieve with every other disease. And yet we still have a lot of the same problems and kind of troubles making progress in intracerebral hemorrhage, which maybe now there's a little bit of optimism there, and subarachnoid hemorrhage and refractory status epilepticus and all these other areas where we're not doing a lot that's so different from a treatment standpoint than we were probably 10 or 20 years ago.
But one of the other differences that I'm seeing in the ones that we might not have made much progress in treatment strategies, and one of the big strengths of neurocritical care is that some of these patients were giving time to recover.
Yes,
And I think
absolutely.
that's huge, particularly, you know how many status patients you'll have in the unit intubated for like 2 months, but a year from now, they're actually doing okay. Whereas if these patients were in medical ICUs, and I mean, forgive me, I realize that the um, life expectancy in a MICU is much different than a neuro ICU, but these patients survive. Even ICH, like we're having, if they're in a neuro ICU, they're more likely to have a positive outcome or something that they can live with anyway.
I completely agree. We briefly touched on this during the interview, but as we're coming to a close here, I can't help but reflect on how large a role you've actually played in the Neurocritical Care Society and SCCM as well. I knew of you long ago just by your leadership positions and the workshops you're involved in, you've been involved with. How have those societies shaped your career, and how can we encourage more APPs to get involved with NCS in particular? Because I think it's something of course, we want NCS to represent the full, diverse, multidisciplinary group of neurocritical care. And I think we still have a long ways to go in really engaging the APPs that work in our field.
I think one of the most important things for everybody is whether you're a bedside nurse, whether you're an APP, if you're a respiratory therapist, a pharmacist, is to have the confidence to say, I bring something unique to this table and my contribution is valued. And the societies you mentioned, obviously NCS, which this is for, and then SCCM as well, truly feel like that. And they live that in their actions, which is why we have presidents, board members, we have real representation at the table. And the only way to sustain that is by continuing to grow people that believe that they deserve to sit at that table. And the next question that always gets asked is, how do I do that? And it's really simple. You show up, and then if you say you're going to do something, you follow through. What's been incredible over my time, like actually working with these societies, is how many people don't show up, they don't come to meetings, and then they say they're going to do something and then they never do. It's really simple. You show up,
Yeah.
and if you say you're going to do something, do it. And then people will remember you. Something I was told early on was, if you're at a meeting, make sure that you always say something so that people know that you're there. I think that's smart advice. When you're just getting started, if you're not to the stage that you want to volunteer to do something yet, just let people know that you were invited and you came. And then the next meeting, when something is in your wheelhouse, say, hey, I can do that, but then do it. It's really easy, and that's how you grow. You might start as an item writer, and then 20 years later, you might be president. So just take the opportunities when they come. Early in your career, say yes instead of no, and then follow through. It's really, really simple.
I love that advice. We finish each one of these interviews with a couple of sort of quick hit questions just to get to know you a little bit better. Do you have any passions or hobbies outside of neurocritical care?
So I am a pilot in my spare time. So I'm getting my pilot
Wow.
license, and there's nothing I love more than being in the sky.
Very interesting. Well, maybe that goes into our next question. What other profession would you have liked to have attempted?
Oh, I wish I would have found this like 40 years ago. If you just see, this is where you're going to miss out from the video, is the cat just tried to jump on the desk and missed. So obviously I would not be a cat trainer. Yeah, I wish I would have found a career in aviation early on, but I think everything happens for a reason. So I'm glad I am where I am.
Very interesting. I sort of, there are a lot of parallels between what we do in neurocritical care and the aviation industry, I think. So that makes
Yeah, I
total
love
sense to
that,
me.
actually.
What profession would you not like to do?
Oof. You know what? I don't know that I'm above any profession. Like, this is a conversation we've had. If for some reason I would lose everything, and tomorrow, if I had to work at McDonald's, I would do it. So I don't know if there's anything that I like would absolutely not do.
Fair enough.
I'm here to work, and that's whatever you have for me, I'll do it.
All right. Is there a sound or smell in the ICU that you actually like, or you find some bit of nostalgia in?
I like the smell of EEG glue. I don't know why. I really do. I don't like sniff it or anything, but like some people find it super offensive. I kind of like it. Same with Onyx. I like that smell
Oh,
too.
you like Onyx? I was going to ask
Yeah.
you about Onyx then.
Yeah, there's something about it that doesn't bother me. I find it pleasant. I don't
Um,
think I'm huffing it or anything, but
yeah.
like I do like the smell.
That's funny. I feel like in our unit, Onyx glue is the one thing that everyone complains about. Like, oh, we got one today.
Yeah, you can smell it from the hallway. Yeah.
Yeah, yeah. Well, how about the opposite? Is there a sound or smell in the ICU that you just can't stand?
So I cannot do a million alarms. Something about that drives me insane, because if everyone is sitting around and there are a million alarms going off, then why do we even have that as a
Mm,
possibility? Drives me up the wall. I will go and either silence everything or go in every room. It does. It like alarm fatigue is real, but I don't have it yet, so it drives me insane.
If you haven't gotten it yet, then maybe you're somehow resistant. We have to study you. Um, and lastly, what advice do you have for, a new NP grad, let's say, starting their career?
So I think I was never more confident than when I first graduated. And then obviously I shared the story that kind of broke that confidence. I think go into your career knowing that you will learn something every day, that we are all fallible, and that the most important thing that you can do is be humble. Like be there for the right reasons and be humble. And that's how you'll grow.
Yeah, I love that. I think we've somehow created this myth in the neuro ICU that everyone has to know everything and be perfect. And it's just not true. And
Attainable.
yeah, and sometimes this is, I think the other side of that is sometimes you can actually know what you're doing and you can still have a bad outcome because people are really sick and sometimes sickness wins and it's not anybody's fault. So I really like that idea of being humble in the ICU.
It's important, but it's funny. It's almost like the more you know, the more you realize that you don't know. And so I see it comes with time.
Yeah. Well, thank you so much for joining us. This has been a pleasure, and I'm so glad to. I've been wanting to have an APP on this part of the podcast for a long time, and so thank you for being the first, and hopefully there'll be many more. This has been the Neurocritical Care Society podcast. We are available anywhere you get your podcasts. Please like and subscribe, and continuing education credits are available for select episodes. Diane, thanks again, and to listeners, please join us next time. Take care.